thanking you for how incredibly hard you've all worked this year. It's been extremely challenging. I am certain that none of us expected our first APIC Great Lakes meeting this year to be virtual and to be in August. I certainly didn't expect that. I feel like our work is often thankless and unrecognized, and so just want to make sure that we take a moment here today to express our appreciation and our gratitude for all the work that you've done. I am fully confident that lives have been saved because of you and your efforts. I know that our patients and our healthcare personnel and even the general public are safer because of the work that you all are doing. And they continue to be safer today because of the work that you're doing. I also just want to say thanks for attending today. I know that COVID is still taking up a lot of our time. I feel like a lot of our regular work is returning and some of those usual expectations. And then it's summer and a lot of people try to take time off. So we really appreciate that you're taking some time out of your day to be here with us today. And I also just want to say, you know, it is summer. We've got a little breathing room with COVID compared to the spring. Think about taking some time off while you can. So I'll just move into a few quick updates that are APIC related. So starting out with, I wanted to share, there was a CBIC email earlier this week that indicates that they're granting extensions for 2020 recertifying individuals. So I think that's excellent news. Just be mindful of those details. You do still have to register, buy, and purchase by November 30th. But if you're going to recertify by the new infection prevention units, you have until January 31st of 2021. And then if you're going to be recertifying by exam, you have until March 31st of 2021. So just a couple of dates to have there if you are a 2020 recertifying CIC. And then from there, I just wanted to share that, you know, APIC has a COVID-19 task force that is actively working on putting together resources and keeping those up to date. They also have started doing webinars. There was one on July 30th, which was recorded, and that was around aerosol generating procedures. They are also open to questions from infection preventionists, which you can submit by emailing practice@apic.org. Also want to share that APIC wants your COVID-19 story. APIC is currently requesting videos and photographs, and even you can just go in and share your thoughts and feelings to tell the story of the work that you've been doing during the pandemic. And so there's a link here in the slides for you to be able to share your COVID-19 story. And then also, you know, we're almost to October, even though this entire year has been pretty much a blur. But in October, we will have International Infection Prevention Week. And as part of APIC's Communications Committee, I get kind of a sneak peek of what's going on with our International Infection Prevention Week theme. And I'm just really excited about this year. It really plays off of the We Love Our IPs theme, and is going to be making a lot of efforts to help recognize the really important work that y'all have been doing, no matter what practice location you're in. So there's just a link there that takes you to the promotional toolkit, which can help with some information sharing. And then that is really all I have. So if Martin or Amanda have anything to add, otherwise I can turn it back over to you, Kelsey and Chow.
Thank you, Beth. This is Martin. I don't have anything to add, but I appreciate your comments. Thank you.
All right, Beth, Martin, thank you so much for your comments. And we will move into the treasurer's report. So Karen and Rebecca, turn it to you.
Great. It's nice to see so many people on today. I think it's a really great idea to have these meetups, and I hope we have some more before the end of the year. I'm Karen Jones. I am the current treasurer. I'll be ending my term the end of this year. Last year, we added in a new position, the treasurer-elect. Other larger chapters actually have this position, and we thought that because the treasurer does manage so many things, that it would be a good idea to bring that role in. So Rebecca's on as well, and we've started the transition over. We've met up a couple of times, and before the end of the year, she's going to be taking over the responsibilities of the bank accounts. So just to give you, if you want to take a look at the slide, our account balances, we have two accounts for APIC Great Lakes. We have a checking account that's through Comerica, and our current balance is $11,003.46, and then our savings account, Capital One, $7,428.46. This is probably the highest that our account balances have been. And that's not really a big surprise because we haven't had much movement. We haven't had many receipts, disbursements at all for 2020, which is what we would expect given the pandemic and the inability to hold our in-person programs and meetings, unable to engage with our vendors as we normally would. So we do have our approved 2020 budget and our 2019 financial reports. Those are available, always available on the APIC Great Lakes website. I was going to add a screenshot in there, but if you go to the members only tab after you sign in, there's a tab for treasury, that's what it's marked. And it's got, historically it goes back to, I want to say like 2015 for the reports. But I make sure that when, after we report those to the board, they get uploaded up to our website so all the members are able to take a look at that. I already talked a little bit about our transition to treasurer-elect. The last thing, and I don't have too much to report on this right now because the board is going to be meeting as a group tomorrow, I think, to make a decision on certification exam reimbursement. So if you are someone that is interested or already has taken the certification exam for infection prevention, we are looking to be able to reimburse you for the cost of the exam. So what we still need to hash out is how many we're going to be able to cover. And we'll definitely, once that's decided, we will distribute that among all of the members to make sure that you get that information and you can fill out. We have just like a quick little one-pager. Again, this is for individuals who are not able to be reimbursed for exam fees from your employer. If anybody has any questions, you can either type those, I don't know if we have a chat box, or you can just ask me right now, or you can even email those to me.
Thanks, Karen. This is Kelsey, and there is a chat box. So if that's something you're interested in, you can chat to Karen directly. And as she mentioned, once the board is able to make a decision on what those exam reimbursement fees look like, there will be more widespread communication. So this certainly is not the last you'll be hearing about it. But Karen, appreciate you giving a heads up on what's to come.
For sure.
Okay, so we will move into our membership chair report. So Jordan Bosco is our current membership secretary. And at this time, there's nothing of note to report. So we will keep moving. And next is Jen Madigan, who is our bylaws chair. And again, nothing to report from this standpoint either. Okay, so moving into a legislative update. Lisa, I will turn it over to you.
Great, thank you. Can you guys hear me?
We sure can.
Okay, thanks. Thanks, Kelsey and Xiao, for pulling us together today. I think it's really important that we stay connected. These are very valuable times to lean and learn from each other, so thank you very much. A quick update. So I have a partner with bylaws, or with, I don't even know what I'm doing, regulatory, and that's Noreen Mallon. She's going to give a local Michigan update. I'm going to speak to our national activities. I'm vice chair of the National APIC Public Policy Committee. So we have been very active since, well, we're always active, but we're even more active with COVID. But we really need you to be active too. National APIC does track by chapter the amount of members that email or text their representatives through the links that I'm showing here. So I'll put this, if you can't see the website, apic.org/COVID-19, I'll put it in the chat box if you can't see that link, but Beth referred to it in her opening. APIC has stood up a really good task force with this COVID website, but right on the homepage of the COVID website for APIC are the ways for you to get active with your representative. So you can sign up to get action alerts. You can, from there, you can send template letters. You can customize them if you want, but it's, you know, advocating and telling your state representative, your House rep and your senator for your region that we need more PPE funding for different things. But we really, really need you to take a minute to do this. Without you, public policy and all of APIC's efforts to push Congress and the president and all the other organizations in Washington to advocate and support us is not as effective. So next slide, please. What have we been doing at the national level? We have been writing a lot of letters for COVID. We've written letters to the federal government in response to federal registers in regards to data collection burden. We've written APIC National joined with SHEA to write a very strong letter to Vice President Pence about dropping the NHSN COVID module and moving towards the other process. We've written letters on collecting a data burden, collecting healthcare professional SARS infections. We've written letters to CMS in response to Medicare Medicaid programs for SNFs. We've also signed on to dozens of other organization letters, including a large letter to the United States federal government about dropping funding for the World Health Organization. The newest feed of letters that are coming in are around antimicrobial stewardship and concerns over what happened to that during COVID, as well as vaccination funding in the importance of not dropping routine vaccination funding in light of the impending COVID vaccination. So if you want more news on what we've been up to, you can go to that link right there. There's also at that link a whole bunch of updates on what's been going on with the FDA, with all the emergency use acts, as well as a bunch of other things. So that is all I have from a national perspective. Please feel free to email me or reach out if you want more information. You know, last year we had talked about doing a road trip to Lansing to talk to our representatives in person. Obviously with COVID that got a little derailed, but hopefully next year we can revisit that opportunity. Thank you, and now I'll turn it over to Noreen.
Yeah, hi everybody. It's great to see everybody and hear everybody too. There's been a flurry of activity, but I can't echo enough what Lisa said about, you know, trying to get involved and contact your state and local and national leaders to advocate for what is important to infection prevention. I can add that there was, on a state level, there was a bill to kind of make the state health department develop and operate a centralized intake facility in each of the 8 healthcare regions to provide care to individuals who test positive for coronavirus and are ineligible for admission to a hospital. So this is a long-term care bill. It did not go through because there are other ways that they're handling this right now. So I will say to go to the michigan.gov/coronavirus website, and there's a ton of information there about what's happening in long-term care. But that bill that I just spoke of did not pass the House or Senate. So other than that, I'm still getting pretty connected back into the state and the legislative part of it. So I think that's all I have for today, but thanks, and we'll talk to you soon.
Thanks so much, Noreen. So we will move into nominations. Chair Marissa, I will turn it over to you for an update.
Hi, everyone. I just want to let you know that there are going to be 6 open positions for APIC Great Lakes Board in 2021. We have 1 position for president-elect. So this is a position that you kind of learn the ropes for the first year, and then you go and you're actually president for 1 year, and then you're the past president for the 3rd year. Membership secretary, it's a 2-year term, and we have 1 position open. And then for nominations committee, there are 3 open positions. Sorry, so there's 5. And so the nominations committee, it's a 1-year term, and we have 3. So if you're interested in running for any of these 3, you can send an email to us, or you can send a little message in the chat. So we'll have to start getting people's bios for the nominations and election period, but that'll be coming soon. I think that's all I have for this.
Great, thanks, Marissa. And so I would just encourage you, if there's anybody on the line who is thinking about it or considering becoming more involved with APIC Great Lakes, I think running for a position on the Great Lakes Board is a great way to do that. So certainly feel free to reach out to Marissa, reach out to any one of us on the board. I think we're all more than willing to share our experiences and kind of give you the nudge you might need to sign up and participate. So I wanted to spend a little bit of time talking about kind of where we are and what we're thinking about for the rest of this year. It's become very apparent that convening our chapter in person is probably not going to happen much before next year. So what we have kind of done in response to the survey, which we'll dig into a little bit here in a few minutes, but we wanted to make sure that we're still able to provide education for the chapter. I think this is especially pertinent given all that's going on with COVID, and we've just really been kind of up to our eyeballs in this. And so we really don't want to lose sight of the continuing education that APIC Great Lakes has so diligently provided. And so we just want to make sure that continues. So we do have 3 events that we're planning, 1 per month across September, October, and November. We have confirmed Dr. Marty Sunland from the MDHHS lab, and she is the Director of Infectious Diseases. So she'll be with us next month, September 23rd, talking about kind of the lab perspective of COVID. For October 21st and the November 18th session, at this point, we are still working to confirm speakers, but we have been in conversations with the state epidemiologist for the October 21st session, just to kind of talk through the epidemiology of COVID, what we're seeing here in the state of Michigan, as well as sort of a national global perspective as well. So more to come on these events, but just kind of wanted to give folks a heads up that we are in the process of planning them, so you can save the date now since calendars fill up quickly. The one other thing I would note is that we are working to secure CEs for these 3 events. I know that especially now that we have the opportunity to use the CEs and IPUs to recertify, to keep our credentials, that this is going to be an important piece. So we are working on that. So just kind of wanted you to be aware as you're planning to attend. And just so you're not scrambling to write all of this information down, the slide deck that we're going through today, as well as the recording of our time together, will be posted. So you'll have all of this information kind of in follow-up to our hour together this morning. So with that, Chow, I will turn it over to you to talk a little bit more about what we're planning on the education side.
Thanks, Kelsey. So we know that with COVID canceling all of our national conferences this year, and we know that, you know, a lot of our members probably had a poster or presentation or any abstract that was accepted. So we would like to allow our members to present any talks, posters, or other projects that you guys had planned to deliver at the conferences to our chapter members at upcoming virtual events. So, don't let your work and achievements that you've accomplished prior to COVID sit in the dust, and we would love to see your work and learn from you. So if you're interested in presenting, please feel free to reach out to Kelsey and I on our email address listed here. Next slide, Kelsey. So back in June, we sent out a survey seeking your feedback on how, our chapter might continue engaging you guys and providing a safe space for open dialogue around hot topics and important questions during a time, right now when infection prevention expertise is needed more than ever. And so thank you to everyone who participated. We had a total of 36 responses. And as you can see in the word box on the left, those are the responses from participating health systems. So we have Spectrum, McLaren, Beaumont, Ascension, Bronson, and then the word box on the right are the titles of some of the individuals who responded. So we could see that there's a list of various roles that participated in this survey. Next slide, Kelsey. So 97% of you guys are interested in virtual question and answer sessions, and then the majority of you guys voted for monthly or quarterly virtual question and answer events. And so we did take, your answers into consideration. So this survey actually helped us started this first virtual event. And like Kelsey had shared earlier, moving forward for the rest of the year, we're hoping to host monthly virtual events, with speakers and opportunities for you guys to present your work. And then also some of the top 10 topics of most interest are listed on here. So you guys stated that, you're interested in discussion about PPE conservation, innovations during COVID, some alternative PPE products, and employee testing, and the list goes on. So with this in mind, we're hoping that some of our future events will have speakers who will cover some of the topics of interest displayed here. And also the second half of the session today, we're hoping to kind of, prompt some of the discussion on these topics here. Next slide, Kelsey. So with that being said, so we're 4 minutes ahead, which is great. So for the second half of this hour then, we're going to turn the floor over to you guys who are on the line today to openly ask, discuss, and share anything related to COVID. And it can be non-COVID too, I know that we've all worked tirelessly and extensively for the last 5 to 6 to 7 months, depending on, when your facility started preparing for COVID, that maybe it might be great to even talk about something that isn't COVID related. So now we're just going to jump into the COVID-19 sharing session. And as I said on here, we're sharing information, not the virus, to each other. So feel free to raise your hand to speak, or like Kelsey said, there is a chat box and you can type your question there and I will monitor the chat box and read the questions out loud. Or if you would like to grab the mic to speak, you can press *6 to unmute yourself on your phone, or you can unmute yourself from your participant control panel. So I am going to give it probably just a minute to see if anyone submits any questions or unmute themselves to ask a question. We do have a slide of canned questions that we've put together to get the conversation started if you guys don't have any questions for us.
Hey, Chow, it's Rebecca. Can you hear me?
Yes.
It's so good to hear all of your voices and see some of our faces. So thanks for
Hi, this is Sharon Cordes.
Oh.
Can you hear me?
Hi, Sharon. Yeah. We can hear you.
Sharon, did you have a question, or can I go ahead? I was going to bring up a non-COVID topic. It's not really a question, but just to get a pulse check, and you can use the chat or chime in here. I was just wondering, we as a board, we've met a couple times, and we talked about the CMS exceptions for NHSN reporting. And just wondering to get a pulse check, because we have such a great number of people here, if people are reporting as usual. And I'm just curious from what the Michigan data will look like overall. And Kelsey, I'm not sure in your role if you have any idea of what that's going to look like yet. But if everybody's reporting as usual and not taking advantage of CMS, or if people are not submitting whatsoever, I would just be really interested to hear your comments.
And just a reminder for those on the line, you may have to press *6 on your phone, as well as unmuting yourself on Zoom.
Kelsey, I didn't know if you had an answer for Rebecca, but this is Chow. And Rebecca, I do have an answer for you, and this is actually what has been keeping me up last 2 weeks since we're slowly approaching the CMS deadline. So for sexual health, we actually ended up submitting our data, but there were many analysis and predictions that actually was performed that we went back and forth. You know, really, I know, like you said, we weren't trying to take advantage of, you know, the waiver that CMS gave us, but it was an opportunity for us to not submit our infection data if, you know, COVID had a negative impact on our HAI data. And for our facility, actually, we found out that COVID did not have a negative impact on our HAI data, so we ended up submitting to NHSN.
And Chow, just to be clear, did you manipulate your monthly plans in any way that, so CMS is going to grab your data? That's basically what you mean?
Correct. Yeah, we did not change our reporting plan. We submitted all the required reporting to CMS.
Excellent. And I see Denise has chimed in, and Rachel Ellens. Thank you guys for your input. That's very helpful. It's better, I mean, I guess it's better if we're all reporting for the quality of the data from a state perspective, and then nationally, of course.
Yeah, and Rebecca, you know, this is one of the topics that's actually been on my mind, really, is how is CMS going to even do, you know, their analysis to calculate that national
I don't think they're going to.
Right, that's a score point, you know, to penalize hospitals. Are they going to do 4 different, like, scores for hospitals that do not submit data, for hospitals that submit all their data, for hospitals that submit, you know, just quarter 1, just quarter 2, and then even talking about, you know, data transparency, will that data be available, like, on Leapfrog or even Hospital Compare, some of the national, like, public reporting sites? How would they display that? Would they remove it? Would they show it for hospitals that submit their data? So we have a lot of unanswered questions. Yeah.
I agree. Yeah, it's been keeping me up at night as well. You know, there were definitely HAIs impacted for us. For those on the line that don't know me, I work at Ascension St. John in Detroit, where we were a hot zone, like the number 3, the 3rd biggest hot zone in the country, and we didn't even really know that we were that hot zone when it was happening. Of course, no one really knew what was going on mid-March there. So it inevitably impacted our HAI data for sure, but looking at what's happening in Texas and now in California again, one would have to wonder if CMS would exclude reporting for them. And I guess I do just worry about when none of us have ever not reported. So the technicality of maybe not having CMS SEER data, removing monthly plans, that can impact any kind of third-party surveillance system that you use accepting the data. So for example, if you get rid of your plans, you can't submit from a third party via HL7 messaging. But yeah, looking to where they're surging now in other parts of the country, one would wonder if this whole year of data is going to be a wash. I've gone through many emotional iterations of where I stand on this. And now it just seems to make the most sense to just report to CMS and let them decide as professional organization, a regulatory organization, what they would share, knowing the quality of the data is suboptimal from a national standpoint. And I certainly, to be clear, I was under the impression that we definitely would not be financially penalized in any of the value-based purchasing programs for that first 2 quarters. And that could change into this quarter and the last quarter of the calendar year too.
Rebecca, I just want to add, this is an opportunity for your advocacy. So I worked with National Ascension Advocacy, and we wrote a letter to CMS. It's still in draft, but in a nutshell, what it says is for all the people that did submit data to CMS, you should not penalize them. You should kind of suspend the hack penalties for January through June 2020, because we have a lot of people that did submit, and it's not fair. So many things are going to be messed up. For those that, Rebecca and I have talked about cherry pick, just submit the good, don't submit the bad. What's going to happen to the national SIR? It's going to go all wonky. So we're just advocating for CMS to kind of take the data, but not act on the data in a punitive fashion. So you could work with your health systems advocacy to do a similar letter.
Can you clarify, and I know you know so much about this, so I thought part of the initial communication from them would be that they wouldn't be including this in the value-based purchasing penalization, right? And so then the hack is outside of that, if you can remind me.
Yeah.
Okay, so they had
two separate programs.
Okay, right.
Yeah.
Okay, well, that's great. Yeah, I hope other large health systems, I know we have representatives of them on the phone, can do the same thing, because I do think that anybody worth their weight in gold is going to see that the data is going to be all over the place, and the SIRs will be probably pretty shocking, and I wouldn't think that they could ethically penalize you on that during this time.
Right. Yeah. But we advocated that they should get the data, because the data might provide, unprecedented insights into what a pandemic does to HAI. If the whole country suppressed, we would have none of those insights, and that would be a great loss.
I agree. The more I've thought about it, I think that CMS actually made an oopsie saying, I think that the intent was sincere to say that we were overburdened, but to see the havoc that it's wreaked with the system, and then not really pairing that with solid NHSN guidance, because of course none of us, as we've said it in our private discussions, none of us know what to do because this has never happened before. Seems like it kind of backfired, that it would have been much easier to just stick to the plan as per usual and put the onus on CMS to do what they're going to do with the data.
Right. Do the right thing. Yeah.
Amen.
Thanks, everybody.
Thanks, Lisa, for that update.
Of course.
So this is Sharon Cordes. My apologies, Rebecca. I had an audio loss there for a minute and didn't hear you talking at all. I have a question about MIOSHA and what everybody's their thoughts are on that. I see MIOSHA's pushing fit testing, and we're finding we're having more availability of respirators, but they're not the same manufacturer. So how are people dealing with fit testing when the manufacturer keeps changing each week or every couple weeks? And by the way, we had MIOSHA come into our facility. We did okay. They wanted to interview employees the nurses that were working on the COVID units, and they wanted the both shifts. So the MIOSHA investigator took both phone numbers, and he called people to find out what the response, and did they feel like they were having adequate PPE. They inspected our PPE closets and storage and looked at our equipment that we had available. It was ended up being a positive survey. We didn't have any problems, except for, of course, they want the fit testing.
Hi, Sharon. This is Martin from Henry Ford Health System. I'll just start by replying that we do require fit testing for any new model of N95. We did run into some challenges with, we ran out of solution, for example, the Bitrix or this saccharin. So our pharmacy ordered the raw materials and made their own Bitrix solution. We did have enough test kits. We just ran out of solution, but we ended up having to do the train the trainer, so we had enough people trained to do fit testing throughout the system.
So the equipment's not even available to order because it's been so high in demand, and we weren't doing fit testing because we had cappers. But now the disposable lens covers are not available for the cappers. So it's been one challenge after another. So there's some places that can't even get the fit testing equipment. How's anybody dealt with that?
We, Sharon, we worked with our innovation team, and they came up with a homemade hood, like, because we couldn't get the hoods because we started fit testing our nursing homes. It was like with a Home Depot bucket and some Tyvek, and it worked really well. They made about 35 of them for us. They're like $6 each to make.
I mean, we're using non-evidence-based systems and having masks that are continual changing. So if you have 1,500 employees or more, you're using 1,500 masks to test, and then you have a different mask the next, a new respirator the next week or whatever. It doesn't seem like, it seems more prudent in a pandemic to be doing CO tests until we can stabilize the respirators and find out what manufacturer we're going to have. I know our corporate's trying to hire a company to come in and do testing, and they're also looking at trying to disperse CN95s per hospital, the same types as they get them in, and trying to do that with supply chain management. But it certainly is a big challenge.
I know.
Karen, we've definitely been experiencing those challenges as well at Beaumont. And, we've really taken the position we're operationalizing with CDC's Fit Under Fire strategy, which is exactly what you described. I mean, doing a seal check by the user, because we are, our supply is stabilizing at this point, but especially during peak, we had every make, model, size imaginable. And so we were really operating with the Fit Under Fire strategy, where you do the seal check, and then if you're unable to, then we were escalating that for a fit test, like a just-in-time fit test. But I feel the same pressure that you're expressing with MIOSHA, and they're visiting us, and I have definite concerns about it.
I don't want to hog all the time, but another quick thing I just wanted to mention was I see that the unions are actively working to promote PPE, which is good, but I was not impressed with the MNA, the way they were saying that if your hospital's not providing it, and instead of saying we want to be supportive and join a union so we could be supportive. So I know there's a lot of unions and non-union hospitals, and even within systems, some of the systems are union and some are not. But I did not see that as a positive move. Did somebody have, maybe Lisa from advocacy, did you see something positive from the unions that seemed, that I didn't see, a different aspect? We're non-union at my facility.
No, in my opinion, the unions are adding fuel to the fire because they're stirring up the pot with their members, and getting them to file grievances when they know the situation we are in. It is not like any of this is by choice. No infection preventionist ever dreams of reusing PPE or extending the use patient to patient. I mean, it's insane, but yet that's where we're at. And I don't think they're doing us any favors. And I haven't seen a close partnership, at least within my union shops. I don't know about the other union shops, but we have unions across the country. I will say one of the devices we're getting, actually the majority of our incoming N95s are going to be the ones with the exhalation valve. And they're commercial industrial N95s. They're not medical. None of them are rated for surgery. None of them have FDA surgical clearance. So we are working on an SBAR consistent with the CDC saying you can cover one that has an exhalation valve. You can cover it with a regular procedure mask to make it safe from the person wearing it breathing out in case they have COVID. So I don't know if others are dealing with that.
Yeah, we're forbidding exhalation valves for healthcare workers right now, but have you worn both masks? I put the N95 on with a mask over, and it's very difficult to breathe. So, and I don't have any breathing problems, so that makes it a challenge.
It is.
Yeah, hi, this is
we're
Martin.
also buying these. Yeah.
Sorry, Lisa, I just wanted to comment, the perspective from Henry Ford Health System, we're not allowing masks or respirators with exhalation valves for our employees or for visitors or caregivers that might come in with patients. We do provide them with a procedure or surgical mask, but we also do not allow double masking in our health system, so.
But Martin, my supply folks are saying the exhalation valves are what's in the pipeline now. So I don't know if you just haven't hit that point yet. We go through 80,000 N95s a month at Ascension. So we're at the point where now that all we can get are the exhalation valve ones, or at least 85% of our supplies are exhalation valve devices.
So the big problem is if they use the N95s for only aerosolized procedures, we'd have enough, but they have people so panicked that they feel they need the N95 for carrying on the COVID floor, and it's not necessary. It's only necessary for COVID aerosolized procedures of suspect and whatever. So I think if we utilized them properly, we'd get rid of half the problem.
Thank you, Sharon, and that is how Henry Ford addresses it as well. We only use the N95s for the aerosol generating procedures, not for every patient.
But the concern is if it's got an exhalation valve, if you're doing an AGP on a non-COVID patient or an unknown COVID or a PUI, and your worker is carrying COVID, they exhale out that valve, they could give a patient that doesn't have it, they could give it to them, or they could give it to a colleague that is maybe unmasked or, eating in the break room or something. So that's the concern, Martin.
Well, that's
it's penetrated
exactly
beyond known COVID.
No, I agree with that 100%, which is why we don't allow exhalation valves.
The same here, and people say they'll wear a mask over, but they don't.
Yeah. Well, you guys might get there.
Lisa, it's Rebecca. Can you speak to, Ascension did some work, right, reaching out to 3M. I can say at St. John, obviously we were a full COVID hospital at one point. We're using the half-piece reusable respirators. The staff has really positive feedback about them. I don't think they fully understand the exhalation valve concept right now. But of course, our policy, which we continue to do a lot of education on, is that they would only use them in the suspect and confirmed COVID rooms. We don't have units anymore. We're not following that workflow at this time. So we're doing a lot of education, making sure that they don't wear those in like a TB room or disseminated zoster, et cetera. And I think that's going really well with just reinforcement and daily rounding. But Ascension had reached out, right, to see could they get a filter for the valve, and I just thought maybe you could speak on that.
Right. So 3M developed a prototype N100. It's called it's the 3M 6000 series. It's like a gray rubber half fast mask. It got 2 filters on the side. Has a big exhalation valve right in the middle, completely open, because I have one and I put water in my mouth and I put the device on and I coughed and the water came blowing right out. So there's like literally no protection for what you're breathing or spitting or coughing or sneezing out. So we pushed 3M, advocated for one with an exhalation valve in it. They developed a prototype and they shipped us six for our whole market or whole health system to evaluate. So I think we gave one to Texas, one to Michigan, one to Florida, Wisconsin, Chicago. And so we're gonna pilot them. Now, the caveat is they're not yet NIOSH approved and they're not FDA approved for surgery, which is where people want to wear these devices. The anesthesiologists and CRNAs, they want to wear these devices all day as they intubate and extubate. They're not surgical approved. They can wear them in PACU and pre-op, but they cannot wear them in an operating room around a sterile field because you're basically breathing out everything. So we just got those prototypes, Rebecca. So we're going to be checking them out, giving the feedback to 3M, and then they're going to go to hopefully market with them. But it's 5 to 6 months away, they said. So those devices, for those of you that aren't aware, they are excellent devices for your healthcare workers that have a high burn rate of their disposable N95, because it's assigned to a worker and it can be wiped in between their uses. And they can't share it with each other. If they share it, you have to think of it like a sleep mask that has to be high level disinfected. But it's a good product for what it's used for.
This is Cal. I'm monitoring the chat, and there is a question from Cynthia Nelson that I'll read aloud. Cynthia wrote, so we don't, as a rule, have N95s on site as we do not take any patients with potential airborne organisms. So we have not done any fit testing as we do not use them. We were under the impression that when OSHA suspended fit testing, we felt we were safe. But now per MASA, MyOSHA is looking at these records. I'm interested in what others are doing from an ASC standpoint by any chance. Not sure if we have anyone from ASC on the call that could speak to this.
This is Sharon Cordes. If you're giving, if you're providing anesthetic and you're intubating the patient, that's considered an aerosolized procedure. So you're going to need to have an N95 in this COVID world right now, or some type of device for that. We also have a hood we developed for surgery that they can put over to decrease the amount of exposure. So it's a clear hood that the anesthesiologists work under when they're intubating a patient. So it's a big, giant plastic clear hood.
So our anesthesiologists are contracted through an outside company, and so they are fit tested, but our staff that works in the ORs are not fit tested. So our policy is they can leave the room during the intubation aspect of the surgery and then wait until that portion is done. But I was just curious because of the new MyOSHA requirement for fit testing records for people who don't, as a rule, do fit testing because we don't use N95 masks on a regular basis. I mean, before COVID, we didn't even have any on site. So I was just curious as to how others are handling with OSHA having suspended the fit testing requirement. Are they running into issues now? So that was my question.
Hey, Shao, can I ask my question about accommodations?
Lisa, this is Kelsey. That's fine. Go right ahead.
Is anybody out there offering accommodations to employees that to exempt them from taking care of a PUI or COVID patient, be it if they're pregnant, if they have advanced age, or underlying high-risk conditions like COPD, asthma? Anybody doing that?
Lisa, it's Rebecca. I know we work for the same organization, but as what happens in real, what happens in policy is not always what happens in real life. So just because we might have explicitly not said these people can't care for, we do have a policy of infectious diseases and the pregnant associate, which is a nice policy that we came up with. But I feel when I'm out there on the floors, staff is very protective of one another, and if there is a pregnant associate, they usually defer that person from caring for anyone with a communicable disease. And I've heard the same for persons who might be immunocompromised. Staff, again, is usually pretty well aware of who those people are. They say them by name and try to avoid them caring for those patients if at all possible. So I think we do have a policy in place, but I think there's a lot on the floors and units where they're just protective of their own.
Yeah, like a code.
Yeah, a bro code, if you will.
You know, we have that too, but we have units that have a high amount of pregnant nurses right now. So I'm not sure how you can do that and fairly do that when you have that many people.
Yeah.
And they can opt to go on to a non-COVID floor, but you still don't, they're still asymptomatic carriers. So the risk might be lower. So I think that's that's a great question.
Hi, this is Martin. One of the challenges that we're currently having, speaking of ADA, is patients or even some employees that may be hard of hearing. So we're trying to get a hold of the masks that have like a clear view window so that your lips can be seen. I know that there are a couple of sites that offer them, but they've been severely back ordered. So we have our Innovations Institute that was looking at creating their own, but that's still in the pipeline. So didn't know if anyone else had any experience with those.
Yeah, we
Martin?
tried to get them too, Martin. The supply, they're hard to get.
Yeah, this is Rebecca. I did, I'm sure you've already looked at this, but I was just reviewing masking information updated on the CDC website, and they had some creative and innovative solutions of using FaceTiming and, some other technologies to kind of overcome that. But I know that's not always feasible.
And there are a few comments in the chat box just regarding some of the staffing accommodations, Lisa, that you were mentioning. Viviana says that they are allowing accommodations for pregnancy, age, and immune compromise. Michelle McRobbie says they don't have a policy, but staff works to cover one another. Denise Parr indicates that their facility has a policy that follows CDC guidance, but their staff works hard to keep pregnant staff and others out of those rooms if staffing allows. There is another comment from B. Warfield about use of clear masks on the dementia unit, which they've indicated works great. So I don't know if you're able to unmute and talk maybe a little bit more about your supply chain and where you get those, if others are maybe having trouble, that may be helpful. Okay, and they indicated they're not able to unmute. That's okay, not a problem at all. So being cognizant of time, I see that we are just shy of the top of the hour. So we can go ahead and just kind of wrap up our conversation for today. I want to thank all of you that joined. I think this was a great first virtual event. I think as the APIC Great Lakes Board, we were kind of unsure what to expect, but you guys showed up, participated, had great conversations. So I hope that this was as meaningful and beneficial for you as I think it has been for us. Chow and I have included our contact information on this slide. If you need to get a hold of either one of us or another member of the board, please feel free to reach out. We're always happy to help direct you to the right person or answer any questions you might have. I think as we mentioned at the beginning, the slides and the recording of this presentation will be available and posted. And so once that has been completed, we'll send an email out to everybody so you have the location of where that's posted and can refer back to this as needed. And so with that, I just want to wrap up by saying thank you so much again. I'm echoing all of the other board members' comments from early in the conversation today. Thank you for the work that you are doing. Thank you for your endless dedication and tireless work over the last 6-8 months. I think, you know, it's like Beth said, kind of a thankless job, but we're all in it together and doing our best to keep our patients safe. So with that, we will go ahead and close our call today and stay safe, and thanks again for joining.
Thanks, everyone. Bye now.